Hello, everyone, and welcome to today's Webinar Wednesday. My name is Devin Smith, Director of Membership and Meetings with Medicaid Health Plans of America, and we're joined today by American Well. Addressing the social determinants of health of your Medicaid members can reduce the costs and improve members' health. But what role can telehealth play in addressing SDOH? During this webinar, Darby Sullivan, Senior Research Analyst at the Advisory Board Company, will discuss next-level opportunities where technology can play a role in addressing social determinants of health, including transportation, lack of nutrition, opioid addiction, and provider availability. Marissa Feller, Director of Network Management, National Medicaid Provider Services at Anthem, will also join the webinar to share how Anthem is coordinating the implementation of its telehealth service, Live Health Online across Medicaid markets, and the impact this has on social determinants of health. And then we'll also hear from Dr. Jenny Carrillo with American Well, VP of Health Plan Solutions. American Well is the leading telehealth platform in the United States and globally, connecting and enabling providers, insurers, patients, and innovators to deliver greater access to more affordable, higher quality care. American Well believes that digital care delivery will transform healthcare. The company offers a single comprehensive platform to support all telehealth needs from urgent to acute and post-acute care, as well as chronic management and healthy living. With over a decade of experience, American Well powers telehealth solutions for over 160 health systems comprised of 2,000 hospitals and 55 health plan partners with over 36,000 employers covering over 150 million lives. So we'll begin with a presentation by Darby Sullivan, Senior Research Analyst with the Advisory Board Company, and then we'll have Dr. Jenny Carrillo lead a Q&A, joining in with Marissa Feller, Director of Network Management, National Medicaid Provider Services. And without further ado, I'll let Darby take it away. Darby, I believe you may be on mute.
Thank you, Devin. I was talking to myself. As I was saying to a muted phone, welcome everyone. My name is Darby, and as Devin said, I'm a population health researcher from the Advisory Board in Washington, D.C. For those of you who may not be quite so familiar with the Advisory Board, we are basically a membership-based research organization, and we serve provider organizations, health plans, medical groups, industry members, pretty much the full gamut of stakeholders across the industry. And what we do that's, I think, is pretty special is I basically spend my entire day talking to the most progressive population health managers and leading organizations to hear what's top of their mind, what they're most focused on. And because of that experience, I know that across the industry, what has become a major top priority is how can we start to make headway in addressing the social determinants of health. So obviously that's a really big question, and it could take many hours to cover that in detail. So for the sake of all of our time, today we're just going to narrowly focus on how specifically we can harness the growing capabilities of telehealth to make an impact here, and what these investments actually look like in the real world. So first, I'm just going to briefly ground us in the true impact of social and environmental risk factors, not only on the health industry writ large, but of course, importantly, on the experience and the outcomes of members. I expect that the majority of us on the line have a clear sense of this, so I'm going to keep this relatively brief. And then I'm going to detail different roles that we've seen telehealth play in addressing some really severe non-clinical needs to improve health outcomes and manage costs. And of course, then I will hand it off to Marissa and Dr. Carrillo, who will have a fireside chat. So to quickly define what we're talking about, I typically turn to the Kaiser Family Foundation because they're an organization that's written very extensively on the subject, and they define the social determinants of health as the conditions in which people are born, grow, live, work, and age, all of which that shape health. And they exist, according to the Kaiser Family Foundation, across these 6 domains. One thing you might notice when you're looking at this slide, the first 5 aren't even about you. They sit outside what has traditionally been within our industry scope of control. But the evidence is mounting that shows us that despite our historical lack of involvement in these spaces, we can't afford to stay agnostic any longer. I don't know about you all, but to me it feels like every week I'm seeing more and more academic data that publishes what the frontline staff and what public health leaders have been trying to tell us for years. And it's telling us that members have a whole lot harder time staying well when they're struggling with housing insecurity and a job that doesn't pay a living wage and childcare that costs as much as college, which all reasonably impacts mental health and the ability to do something that might seem simple to a provider, a nurse, like why aren't you taking an hour a day to exercise? So at this point, the evidence has shown us that it's undeniable that one's zip code is more important to their health than their genetic code. So the point of this slide, and I'm not going to walk through every data point, but I just want to make it clear that this isn't just a concept we're talking about in a vacuum. These are the realities of our members and our neighbors and our families, and it's life-threatening, in addition to costly, of course, for health plans and provider organizations. In fact, we as the advisory board have done the research that shows that the impact that non-clinical interventions can have on members and providers and health plans. This slide summarizes some of the research my team conducted across a multi-year project to figure out what does the academic evidence say about the impact of different population health interventions. We ended up doing this literature review on 45 different population health interventions, and it's truly my baby since it took me so long and my team so long to develop. But we've just shown you a summary of what we found for the number of non-clinical interventions that we studied. So clearly there's opportunity for organizations to meet some of their key performance indicators with these investments, really notably reducing cost and utilization. And the reason that organizations can achieve ROI with some of these investments is because the research indicates that social, economic, and environmental factors can influence up to 50% of one's health outcomes. There are a bunch of related data points that are thrown around a lot, but providers know that it's true. The vast majority of physicians are already well aware that these unmet needs directly impact health, but most are at a loss about how they can make an impact. To a certain degree, this makes sense. Physicians shouldn't be the ones owning non-clinical care, but they should be at least informed on how to connect patients to the support that they need. Of course, what does that actually mean? What are health plans or provider organizations to do in the space that's pretty unknown for the healthcare industry? We would argue that in the vast majority of scenarios, partnering is the way for organizations to make a real impact at scale. Often when we think about partnering, we're talking about community-based organizations who are already doing great work in the community. But for our purposes today, we're going to highlight how telehealth partnerships can also help achieve some of our goals. So that was a very quick overview, just to make sure we're all starting this conversation on the same page. And I kept it brief, like I said, because by now most people in the industry, even up to the C-suite level, have at least heard of the social determinants of health and understand that this is a growing priority. However, it is rare, I would say, that a provider organization or a health plan actually has a strategic approach to addressing social determinants of health. And even more rare are strategies that include telehealth capabilities. So that's where we're going to spend the majority of our time today. And what our research has shown that there are 3 major ways organizations can use telehealth to overcome social barriers. first and foremost, telehealth capabilities can be part of a solution that helps to meet members' baseline needs. And when I say baseline needs, I mean the type of needs that you have to meet if you want to have any hope of making any type of clinical headway. These are the first priorities in member interactions since they're so key to any ability to self-manage. And it becomes more clear, I think, when we think about what this looks like in practice. So, for instance, if a member can't understand the care that they're receiving or what it really means to take care of their chronic condition, there's no way that they're going to stabilize. And if a member is food insecure or malnourished, their focus is going to be on where or if they're getting their next meal. They're not necessarily considering the nutritional specs of what they're eating. Now, these aren't the only fundamental needs for patients or members by any means, but these are examples of where we've seen telehealth play a role. The second role I want to point out is perhaps the most obvious. These innovations are all about improving access to care, right? The telehealth solutions that we see working for patients to improve access to care are for those patients and members who they have their baseline needs met, but they're still not necessarily accessing the quality preventive care that they need that would help them manage their conditions. But typically whenever I say, hey, you need to improve access to care, that's a very nebulous goal if organizations don't have a clear sense of the root causes of underutilization. There are a lot of different root causes that depend on the community, but one major barrier that we see is honestly the complexity of our healthcare system, as well as the social service system in the United States. Both of these systems are so massively complicated and even hard to understand for someone who day in and day out is studying how these things work, me. And this is where some of those social service referral platforms that have been popping up can be helpful. Some of these are self-service, so these are for members who are more lower risk but still have some social needs. They use these to navigate to non-clinical care. And some of these are actually designed to be incorporated into the workflow of the care team in order to clear up some of that precious time in their day. I would be remiss if I didn't mention that for a lot of members, lack of access to care is a direct result of where they live. Rural patients in particular face very severe shortage gaps to PCPs, specialists, and even hospital care. And telehealth can also play a major role here, of course. And finally, the last role we've seen telehealth play in meeting social needs is by building engagement. When we're thinking about a high-risk, high-need member, this might be a little bit surprising. At the advisory board, we often tell our members, our provider organizations, and health plans that we speak with that they need to prioritize in-person support for these patients in order to really understand their needs and their goals. That is all still true. Telehealth should, of course, never replace care for these members that need high-touch support, but rather they should supplement, these technologies, telehealth should supplement this care for greater chances of success. And the most vulnerable members in particular may need additional touch points to build engagement and trust with the care team. If members aren't engaged in their care, bought into their care plans, your work isn't done. So we'll start with fundamental needs because these are the risk factors that have to be addressed first to make any type of clinical improvement. And one of the most basic components of healthcare is communication. It's the ability of a provider and their patient to connect, to share understanding, and to work together to achieve their goals. Of course, it's not possible if providers literally don't speak the same language as their patient. Patients who aren't the strongest in English are vulnerable to ad hoc translation by family members or by providers themselves who say, hey, we can just get by, we know a little bit of Spanish, what have you. But that can actually lead to misunderstandings, gaps in care, and poor health outcomes. It's quite dangerous. So Cambridge Health Alliance knew that they needed to address this issue. Over half of their patients speak a language other than English at home, and 42% have limited English proficiency. So to address this gap, their leaders developed cross-continuum language support. first, using their website, patients can search for a doctor who speaks their preferred language. And for patients that aren't aware of this offering on the website, clinic staff screen all patients for language needs using just 3 quick questions. Then, once patients are flagged in the system, they're matched with the best interpretation offerings available. So if the patient speaks a common enough language, they are able to access a credentialed language concordant provider themselves or in-person interpreters. But Cambridge Health Alliance doesn't stop there. Patients who speak less common languages can use a range of telehealth capabilities to still receive the support they need, which includes telephonic interpretation, using the language line software, and video remote interpreting for ASL. So in total, these investments into language services has led to a real impact for patients. A recent study measured that Cambridge Health Alliance was able to reduce the likelihood of hospitalization or ED use by 39% when patients with diabetes received the language services that they needed. So I don't think I could get through a conversation on the social determinants of health without mentioning hunger and nutrition. Food security efforts are typically one of the first places that organizations go when they're entering the space. And that's often because our industry can pretty well conceptualize the connection between nutrition and health. So that's food access. But in regards to nutrition, I think a lot of organizations have traditionally focused their efforts on wellness and diet programs, trying to help support behavior change. That's not wrong, but it is incomplete for some patients. In fact, a member who is malnourished spends twice as much on a hospital readmission. So for that reason, malnutrition is an area where a lot of organizations can get real ROI in a relatively short time. One example of this comes from Chicago, from Advocate Healthcare. They decided to take this challenge head on. In 2013, their VP of Innovation and Research came across an academic article that indicated organizations could see sizable gains when they offer their malnourished patients nutritional supplements. So this prompted the VP to go to his nutritionist and his dietitians on staff, and he asked them, and what they told him was that, yes, there's a huge opportunity for preventing malnutrition, both during and after the inpatient stay. So yes, this is an unmet problem, but we're not doing all we can to address it. So that was the impetus of Advocate's Nutrition Care Program. All patients, when admitted to the hospital, are screened for potential malnutrition. And when a patient is identified as at risk, they receive nutritional supplements in the hospital within 24 hours. During their stay, they also get nutrition education and post-discharge instructions. But really importantly for the efficacy here, it doesn't end at discharge. When they're back at home, staff follow up telephonically to reinforce nutritional education, get a sense of remaining needs, and offer coupons for more supplements. So, like I said, for Advocate, the impact has been significant. They were able to reduce readmissions, reduce length of stay, and avoid hospital visits, which totaled to about $4.8 million in avoided costs. So, as I mentioned, for some members, you'll have to meet certain of these fundamental needs of theirs in order to start seeing any meaningful improvement clinically. But not all high-risk members are necessarily dealing with those severe needs. They may not be using ambulatory care, but it's not because they have other needs to address first. But for some, it's because they just can't simply access it. One of these challenges, as I mentioned, is not everyone knows the best way to navigate these complex clinical and social services. So one way that telehealth can play a role is by smoothing the communication and the coordination between the care team and the social services that these patients need. There are a lot of vendors in this space at this point. So I'll just give one example for the sake of time, and that's Pieces Technology, which is a health IT firm that has spun off of the Dallas-based Parkland Center for Clinical Innovation. And Pieces created their DS platform, or Decision Sciences, and it's a cloud-based software that sits on top of EHRs and other clinical data warehouses. And what it does is it can predict and monitor the likelihood of events like readmissions or excess length of stay. DS uses natural language processing to read both structured and unstructured data in the patient chart to identify social risk factors. And then it helps clinicians to create a more personalized discharge plan with those recommendations popping up in the patient's record. Many of the recommendations involve referring patients to community-based organizations. And these referrals are handled in another part of the platform called Pieces Iris. So Iris is also a cloud-based system. It's a care management system that helps health systems and social agencies connect, refer to one another, and they can both actually track patients as they receive services in both healthcare and the community settings. It also allows, really interestingly, different community-based organizations to collaborate with each other. So for example, a food pantry that sees a client might be able to refer someone who needs a job to an employment assistance organization via this platform. And it allows caretakers to go into the system and see, oh, we made this referral, but it wasn't completed. And if it wasn't, we can call up our patient and call up our member and try to re-engage them. And of course, importantly, both DS and Iris are fully integrated into the EHR. And of course, one of the most classic benefits of telehealth is that it expands access to care for patients who face logistical barriers or those who live in underserved areas. UPMC actually uses telehealth to improve access to maternal fetal medicine for women in care deserts. This topic is increasingly top of mind as data continues to grow on the severe disparities in mortality rates for Black mothers and infants. So in UPMC's service area, women with obstetrical complications or other types of medical conditions that put them at risk, they often had to travel really great distances to see a maternal fetal medicine specialist or an MFM specialist. So to address this issue, UPMC launched an MFM teleservices program so that referring physicians and patients could use those services rather than go all the way into Pittsburgh for a personal consultation. So patients themselves can use the tele-MFM services to talk to specialists about their comorbidities. They can also review their records together, and they can even review ultrasound images remotely. So really receiving a comprehensive evaluation of their health and the health of their fetus. Providers can also tap into the service to get consultations, to improve their own education on how to care for women with complicated pregnancies, and also to figure out, okay, how am I going to carry out this specialty recommendation in our day-to-day management of the patient. And what UPMC says is that these early interventions can really help prevent the progression of complications during pregnancy. So lastly, as I touched upon, these interventions aren't likely to make an impact on members' health if they're not fully engaged in their care with trusting relationships with their providers. Telehealth can't necessarily increase trust in provider organizations on a community scale, but it can help engage individual patients or members. One need that it can meet that we've seen is loneliness. This is a non-clinical need that's been getting a lot of news coverage lately. In particular, the former Surgeon General, Dr. Vivek Murthy, has been speaking for years about the scale and the impact of loneliness in our country that makes it at an epidemic level. That can be surprising for some. But for one, research has indicated that loneliness impacts almost half of Americans. And not only that, but to some studies, experiencing chronic loneliness is equivalent to your health to smoking about 15 cigarettes a day and increases the risk of death by up to 45%. These numbers are on par with risk factors like high blood pressure, obesity, and lack of exercise. So in response to this growing and alarming evidence, CareMore developed a togetherness program to help alleviate the loneliness of their senior members. So it works like this. Seniors are screened for signs of loneliness, and if they qualify, they are able to benefit from regular phone calls and targeted in-person home visits with the sole purpose of creating connection. what's really central to the program is the fact that it's the same person calling the member every time, and they begin to develop a relationship with them. CareMore uses volunteers from their plan to make these calls, and they actually report really enjoying it because they're building bonds with their members as they continue to speak to them over weeks and weeks. And in addition, CareMore also has social health hubs in their clinic waiting rooms, which was really smart because they took what was essentially an untapped opportunity, what's normally a very uneventful and maybe even boring period before your appointment, and they made it a space that fosters real connection. So yes, telehealth is a key component in this example, but it's bolstered even further by the fact that it's paired with in-person interaction itself. As you can see on the slide, results in this group showed an increase in exercise, decrease in ED utilization, and decrease in hospital admissions. So this takes me to the last example I want to share with you all today, and it highlights how telehealth can facilitate trust building between the care team and patients or members who are traditionally disconnected or distrusting. This example comes from Kalispell Regional Medical Center in Montana. The provider serves a quite rural area, and when I was talking to them, they shared with me some pretty unbelievable stories about patients who came to their clinics by foot from distances of over 10 miles, literally across mountains. So Kalispell knew that there was a very clear need to offer home visits to these patients who were ill but didn't have access to transportation, and so were trying to get to their appointments by foot. So what Kalispell did was they launched a community health worker nurse dyad program called the Complex Care Team. And the Complex Care Team offers post-discharge support for these rural at-risk patients that have clinical needs, yes, but also psychosocial needs. They decided to use a dyad because they couldn't afford to spend the RN's limited time traveling up to an hour one way. That just wasn't going to work. So instead, the community health worker will take those trips, provide those home visits, as well as weekly telephonic check-ins to help assess and monitor the patient status. Now, during these home visits, the community health worker sets up an iPad so that patients can have a televisit with the RN. That's really important because it gives the patient an opportunity to ask any clinical questions, and it gives the RN a chance to monitor how things are going and seeing if there's any potential escalation. But these home visits and these iPad televisits wouldn't have been possible without the community health worker dedicating time to building trusting relationships with these patients, starting in the inpatient setting. The context I spoke with at Kalispell really reinforced how independent people in Montana are. They're wary of letting other people into the most personal aspects of their lives unless there's a real sense of relationship or trust there, which I think makes sense to all of us. So that's why the community health worker plays such a key role. Her natural relationship building skills and her understanding innately of the background and the community, this was key in even getting that telehealth capability in the door. For patients in the program, Kalispell has reduced inpatient visits, observation visits, and ED visits. So hopefully it was helpful to get a bit of a lay of the land and understand what's even possible in the intersection of telehealth and the social determinants of health. But I know that it's always valuable to hear directly from someone who is involved in running these programs. So I'm going to hand it off to Marissa and Jenny to offer a really detailed insight into how Anthem is using telehealth to address social needs. So Jenny, feel free to take it away unless you're also unfortunately muted at the beginning like I was.
Hi, everyone. This is Jenny Correa from American Well, and indeed, I was typing on mute as well. Pleased to be with you all today. Thank you very much, Darby, for providing us with that very useful overview of the social determinants of health and some great examples of what we see occurring in the communities in which we work with so many of you across the U.S. And really working to address some of these critical needs that we are seeing in our communities. Today, we're delighted to talk with Anthem and what they are doing in particular to really address some of these particular needs that they're finding in their communities that they are serving, and how telehealth is really enabling some of those programs and initiatives that they have developed. So without further ado, I would like to introduce Marissa Feller, who is the Director of Network Management for the National Medicaid Provider Services at Anthem. So Marissa, thank you so much for joining us today.
Oh, it is my pleasure, and hopefully you are hearing me okay. So I'm very pleased to be here today and share some of the work that we are doing at Anthem. I'm currently leading the telehealth strategy for our Medicaid states. Anthem has a large footprint in Medicaid. We currently support 22 states and the District of Columbia with over 3.7 million members. And we have a very large program that address social determinants of health. For someone like me that have been around the block for a couple of times, it's extremely rewarding to see social determinants of health becoming mainstream. In the past, we had the opportunity to be much more engaged with members that we are now. So by having technology, I think we can bridge the gaps and actually work more closely with our communities. So Anthem Essentials. Go ahead.
Yeah,
Go ahead,
Marissa, I was just wondering if you could start by telling us a little bit high level, starting off with some of the approaches that Anthem is taking to address social determinant of health, some of the particular initiatives that you all have in place.
Great. So Anthem Essentials is the program that Anthem has launched, looking to, bring together healthcare and life. So it's a very big commitment, but it goes to the heart of what we have been speaking so far. So Anthem is supporting the daily needs of our members and communities by building relationship and engaging all of the stakeholders to reduce the social barriers, to influence change, and really improve the lives of our members. Also supporting our providers and partners by providing wraparound and support that strengthen the local efforts, and also developing innovative approaches to ensure that members have access to the essentials of everyday life. So we have actually 6 pillars, and I'm going to briefly touch on them and then expand more on the one that talks about telehealth. So the first one are the targeted programs where we focus on housing, food as medicine, and also education, working very closely with community health workers by providing training and internship programs so they can, as we heard from Darby, the importance that they play in our communities. We also are, strengthening the internal culture of the organization and operations where we are centralizing referral systems. We also are updating assessments and care plan tools to include social determinants of health, and also working, in providing more data analysis and proactive engagement, so we can not only address those that are already impacted by social determinants, but also, identify those that are at risk. Then we have our community involvement, where we work very closely with community-based organizations. We sponsor events. We also have a very large program where our associates engage in volunteer days. We partner with our providers and also educate members about access to care. We have a very strong community investment, $5.5 million in local annual foundation grants were dispersed, focused on social determinants of health. We also are doing local capacity building initiatives and also partnering to develop additional opportunities. We also focus on, two more pillars, and then we are going to address telehealth.
Okay, and I just have a question for you after you finish your two pillars.
Sure. So, the outcomes to drive the change, measuring program engagement, which is very important, including telehealth, the utilization impact, reporting on KPIs, and also focus on data that supports the work that we are doing in improving the quality of care. And the last pillar, not the least important, is, looking at the whole person care. Definitely the populations that are, the most needed, telehealth, transportation, doula programs, and also providing clinical days. So these are our 6 pillars of the Anthem Essentials program that we have.
Great, thank you for sharing those with us. So what we know is oftentimes the programs and initiatives that are developed to address the communities that are impacted by social determinants of health and the variety of the different components that make that up, oftentimes they tend to be pretty localized and focus on addressing a specific issue in that community. And what we know is that figuring out how to actually scale those so they can be leveraged in other communities beyond where they might be initially piloted can be a challenge, and yet technology can really enable that and help us expand beyond those initial communities in which we serve. So I'm wondering if you can talk a little bit about how you guys have successfully done that in a community where you started out with a pilot in a local community and then have expanded through technology to broaden the reach of the communities that you were serving.
Yeah, so we have been working with the direct-to-consumer modality of telehealth since 2012. We started implementing the services in the commercial and Medicare line of business. And in 2016, we started to implement in the Medicaid, some Medicaid states. It has been an interesting learning experience because I think we, especially coming from commercial and Medicare, we think that the process should be, exactly the same. And we learned through, the different needs of the Medicaid population that we needed to be much more user-friendly so adoption and eventually utilization could be achieved. So the implementation of in the Medicaid states provided us an opportunity to work very closely with Life Health Online, American Well, to improve, the, registration process and, limit the number of screens that the members needed to access in order to complete the registration, and create educational materials that that can document each step of the process, so the member can go through the registration process without, receiving any information that may deter them to completing the registration. The other lessons learned is also the engagement of the provider community. Initially, we didn't invest so much in engaging providers in the information about Life Health Online, and by providing that additional support to the membership, I think that we are getting more utilization now that we were seeing before. So, we started with the commercial and Medicare lines of business, and now that we are actively expanding through the Medicaid states. We are, again, learning from each state. There are some variations that we need to be mindful about and make the changes necessary so it becomes easier for the members to utilize the platform.
That's great. And, we find that to be the case in many of the communities and with the partners that we work, where we find the partnership between the health plan as well as the networks and providers in those communities with whom they work. It's really critical to engaging with the particular members and patients that are being reached by the programs that are being developed. I'm curious to know, I know that you have just begun these programs, but I'm curious if you might be able to highlight some of the particular outcomes, positive outcomes that you are seeing from this new approach that you are taking with your members in these communities.
So one of the things that we have started to deploy is iPads, right? So as we implement Life Health Online in the different markets, and we are currently have this platform available in 6 markets, expanding to additional 6 until the first quarter of 2020, and hopefully the other markets, in the 2020 and 2021. So we are deploying iPads to homeless shelters, community-based organizations, working with organizations that already support schools to, deploy technology to be able to see members at school sites and make it more available where the member is and needs services. And we heard that, from Darby's presentation, that sometimes, bringing technology where the member is, can facilitate. And if we have the opportunity to work with community health workers, that definitely, improve, adoption. From the membership that are utilizing the platform, there is a survey that is done after the visit, and from a scale to 0, from 0 to 5, the satisfaction with the platform and the visit, the providers in the platform has been very high, like a 4.9 out of 5. So members that come across the platform and are using the services are extremely, glad that they have that kind of access now that they may not have had before.
Oh, that's wonderful to hear, and not something that's unfamiliar to us either. We do know that people really value having that video interaction, the ability to see the provider face-to-face. And while a telephonic connection certainly can also be useful, there's something to be said for being able to see that provider face-to-face that makes it particularly meaningful and continues to foster that trust. And it sounds like your strategy of delivering the iPads to the members right there in their home is really beneficial in the programs that you are rolling out. So one final question from Marissa. What do you see on the horizon for you all as you continue to expand and think about how you can leverage your telehealth platform for your members and the communities that you are serving, and particularly addressing these key social determinants of health?
So definitely, expanding the services that we have available, looking at nutritional counseling, definitely, bringing, specialist services to platforms, expanding, the other modalities, of telehealth, like remote patient monitoring, engaging with organizations that, utilize text messaging that are culturally and linguistically appropriate to increase engagement. And I think that regardless how we feel about technology, I think we are at a position where there is no return, right, from where we are. And I think that the demand is going to grow, as the technology becomes more affordable and improve We are hearing now about, sensors that could be available to be installed in members' home, where, they can be monitored and cared for within their own homes. And I believe that this is going to be the future. So, focusing on what is coming next, and being sure that is appropriate. And of course, we have to evaluate and work towards utilization and adoption, because technology is still, not well embraced by everybody, not because people don't want, but it is something new that they need to learn how to operate.
Yeah, building that awareness can be so critical to enabling these programs and making sure that people feel comfortable and familiar with the access that they have, and certainly can appreciate the emphasis that you all will be having and continuing to build that. It sounds like these programs that you have built out already in the past and that you have on the horizon are exciting and certainly going to be meeting some really critical needs for your members. So I'm delighted to hear about those, and we look forward to hearing more about your successful implementation of these programs. Well, I think at this time we can, I think at this point we can go ahead and open it up to questions for those on the line. I believe, Devin, you are going to be guiding us through the questions.
Yes, absolutely, and thank you so much, Jenny and Darby and Marissa. I will move into the questions. So we had a few questions kind of on the same topic in terms of if you have Medicaid members who don't have the economic means to access technologies, or they have no phone or limited data on their Obama phones. So what are some ways that some alternative solutions for that population in ways that they can engage in telehealth?
Marissa, did you want to talk a little bit about that, or otherwise I can talk a little bit about that? Well, I can talk a little bit about what we're seeing from just kind of the various different partners with whom we are working across the country. Indeed, we know that there can be challenges in terms of people having access to devices. As you heard Marissa talking about, obviously they were giving iPads that expanded obviously beyond the Obama phones, as they were called just a second ago in the question. And so that certainly is one way. We also have seen folks actually equipping some of their members with data plans, recognizing that the cost of those data plans actually are more valuable than the cost of care that they might incur by otherwise going to other services to access care, where there might be a higher cost of care. So we have certainly had partners who have gone ahead and chosen to pay for those data plans for their clients and members. And then also what we do see as well is that we know that, those folks who are, who might not have a computer and internet access in the same way are oftentimes the most savvy Wi-Fi users of public access and know where to go, so they are able to actually access public Wi-Fi. And one final thing I'll just mention, oftentimes we see community centers also being equipped with kiosks and other kinds of technology that our software runs on, where their libraries or other kinds of community health centers where their members can go to that are right there close by, and will also enable access to other providers that expand beyond perhaps who they can access right there in their immediate neighborhood. So there's a number of different ways that we're seeing people equipped with the technology to ensure that they are having greater access to care. And I don't know if Marissa or Darby, you want to add anything onto that?
Sure, I'd love to add a little bit more. I think what you said all makes complete sense, and I think the question is a very valid one, which is, are we looking at these type of telehealth technologies as a magical bullet that can address really complex problems for people who may not be represented in the program design itself? I think that's a great point, and telehealth has to be just part of a solution for a member or a patient who is experiencing a number of different social needs. I loved your point, Jenny, about, sure, you can give someone a smartphone, but if they can't pay their data bill, it's useless. Or you can give someone, this technology, but if they're going from shelter to shelter and they're worried about, the safety of their belongings, it's not really going to be effective. So I think what it comes down to is really a deep dive into the community that you're trying to serve, the broader community, but also more specifically, population that you think is going to benefit from this telehealth service. Having a very clear sense of what their challenges are, what their strengths are, and what they want to get out of this program, leading rather than, following their lead rather than taking the lead yourself. I think that ensures that no matter what type of program you're designing, no matter the type of role that telehealth is playing, you have a greater chance of success of actually helping the people you're trying to serve.
Yeah, and I apologize, I was on mute when I started responding, but, it's exactly, what you said, both of you said. We do try to map the resources that exist locally. There are some areas that, unfortunately, there is no connectivity. So, we need to understand what the local resources are that can benefit. But another point is that as telehealth becoming, more and more utilized, I think that we are seeing progress in terms of new regulations and funding to expand broadband. And I'm hoping that in the next, year or so, we are going to be able to have more connectivity than we have right now. So it's just a matter of time to catch up all of the work that is being done by the states and the federal government.
Great. Let's see here. So we have another question. What patient populations are the highest utilizers of telehealth services?
We at American Well are seeing a high utilization across all of the different members that are being served. I don't know, given that we are talking particularly about social determinants health, maybe we can kind of narrow this a bit in scope. Marissa, perhaps in all the different programs that you are personally running, I don't know if maybe you want to talk about where you're seeing the fastest rate of adoption in the various different programs that you are implementing, obviously knowing that you still have many more to roll out.
Sure. So, from the data that we have, females are the ones that use the platform the most. I think the gap is more visible in behavioral health. I think that we can do more because the difference is more than 40 percentage points between females and males using the platform. The average age is around 30 to 40 years of age. So in terms of what we have been collecting, it doesn't mean that older members are not utilizing, but I think in terms of our data is the younger, around the age 30 to 40 and females. Interestingly, we thought that they would be accessing the Life Health Online platform more on the weekends and evenings, but that's not true. The utilization is usually between 1 and 4 in the afternoon. Mondays are the heavier days, and this is for the on-demand. One of the things that we noticed that we are going to be focusing on moving forward is that we are seeing a very high percentage of no-shows for behavioral health. And, we know that there is a lot of different reasons why a member may, have an appointment and decided not to go through with it. But still, if we consider that there is no issue of transportation, that, the language barrier is addressed by the technology, we need to do better, in decreasing the number of no-shows. So this is a couple of data points that we have been collecting from the programs that we have live.
Great. And then we have another question. Communities are variable and have unique needs. How can we focus on strengthening partnerships with community-based organizations without losing connection by trying to standardize or create even more complicated healthcare pathways, which they reference is an issue in the first place?
Darby, do you want to talk about some of those successful partnerships that you've seen, and Marissa, how you've kind of enabled those in the communities that you've served as well?
Yeah, I'm happy to, and I actually would love to hear Marissa's thoughts because she mentioned her work in capacity building. I think part of where this question might be coming from is some pushback that we have gotten from community-based organizations who are saying, okay, now, provider organizations and health plans are realizing that social needs impact patients' health, and they are realizing that they have really great opportunities for partnership in us because we've been doing this work for so long and we have such deep-seated trust in the community. However, even though the referrals are great, it's not necessarily sustainable for our organization that, is running on even tighter margins than hospitals are and may not have, robust technology arms or grant writing arms. So I think a lot of organizations are pushing back now and saying, okay, we're very busy and have such tight margins that how can you make this smooth as possible? How can you make it, so it's not as much of a burden on us when we're typically used to serving this many clients and now it's been raised. Part of that, I think, goes back to some of the platforms I was talking about, like Pieces, but also I think a lot of people have heard of Aunt Bertha or Unite Us. And these are all brand new ways that I think organizations like provider organizations can incorporate some of these tasks, goes directly into the EMR, and it can go directly into the technology platforms of community-based organizations to simplify as much as possible this type of communication and coordination. I think in terms of this planning, it's helpful, like I said, to have a really great sense of what the needs are of the community-based organization you're working with, so as not to accidentally create some of those more complex pathways than we're already dealing with. I think another exciting development is Epic's new module on social needs screening and how people are excited about how that's going to streamline patient care. I've yet to see some really great examples of people implementing that over a number of months, but certainly something I'm looking at.
Yeah, and for us, we definitely, want to identify the community-based organizations that, our members are accessing and, through either grants or even, helping them create programs to help us identify those that are, either at risk or already impacted by social determinants. That's the opportunity that we have to, build capacity and work together.
Great. Well, it looks like we are out of time. If your question wasn't answered, I know American Well will be sending a post-webinar follow-up to all of our attendees today. So I want to thank everyone for joining us for this webinar. Thank you to American Well and the advisory board and Anthem as well for leading this webinar. And we hope to see you all on another webinar Wednesday. Have a great weekend.